Welcome to the lecture on osteoarthritis. I'm excited to talk to you about this because I am sure if you choose a career working with adults, you will see osteoarthritis. Now, this condition isn't one to be a huge game changer in your patient's care. It's not like there is some kind of emergency that you have to watch out for. While it may seem like a non-issue, the disease can, in its advanced chronic stages, be debilitating. When I hear a patient has OA or osteoarthritis, I know I may need, say, more time to get the patient out of bed, or I will look extra hard to see how they are feeding themselves with their gnarled, stiff hands. I mean, is there enough dexterity to prepare food? Administer medications to themselves even? Shoot, what questions or assessments do I need to even do to determine if OA is even worth bringing up or assessing on my patient? Are you ready to learn more? Well, what are you waiting for? Let's go. OA, or degenerative joint disease, such as DJD, is a disorder characterized by progressive deterioration of the articular cartilage. OA is the most common type of all the arthritis out there, and it's a major cause of disability. We consider OA as a non-inflammatory condition and non-systemic disease. However, occasionally a joint does get an infection in it, and in that case it would be an inflammatory process. But most cases, we consider it non-inflammatory. It is no longer thought to be a wear and tear disease associated with aging, but rather it's a process in which new tissue is produced as a result of cartilage destruction within the new joint. The cartilage and bone beneath the cartilage erode and the osteophytes form. Osteophytes are also known as bone spurs. These result in narrow joint spaces and cause a lot of pain when moving. Early in the disease process of osteoarthritis, it may be difficult to distinguish osteoarthritis from even rheumatoid arthritis. There are two general categories of risk factors for why somebody develops osteoarthritis. There's the primary reason, which is basically a combination of age and genetics. In fact, age, what's important to know is the majority of adults who are over 60 years old do have some joint changes on X-ray. For some secondary causes, we have obesity, smoking, people who have repetitive stress on particular joints, such as manual laborers, people who are on their knees, maybe even our athletes. Our pitchers oftentimes will end up with osteoarthritis in their pitching arm. Some other secondary osteoarthritis reasons may be less so, but can be possibly there. I already mentioned obesity, but trauma can lead to OA, diabetes, and sickle cell disease. Once again, please remember that no one is admitted for an osteoarthritis emergency. There is no acute condition. It's just going to be this other disease that you're going to find in somebody's history that you're going to have to just kind of compensate for in whatever the patient's disability may be. So I walk into my patient's room after hearing that they have osteoarthritis. What am I going to see? What is going to be their history and their story? What questions should I ask? All good things to know, because first, when we have a patient with osteoarthritis, we're going to notice that they have pain and stiffness that actually resolves with rest and inactivity. So, that being said, give them periods of rest. This is actually a sign of early osteoarthritis. Unfortunately, in later or advanced osteoarthritis, they just have pain which occurs at all times, and even with the slightest motion or even just sitting and being at rest. So let's focus a little bit more on the early or say moderate stages of osteoarthritis. Their pain is going to occur mostly in the end of the day. It's going to occur at the end of the day and on weight-bearing joints or joints that are excessively used, really. The pain is going to be present when you palpate it or do some kind of range of motions. I know I've had patients before when I ask them to reach up and grab the arm rails above their head to pull themselves up in bed, and you'll see that their face grimaces. And I'll say to them, "Oh, are you not able to reach that high?" And they'll say, "No, I haven't been able to reach that high in years." Okay, in that instance, I don't try to force their arm up. I will go and get another nurse to help me scoot them up in bed. If they have osteoarthritis in their hips and their hip joints, you're going to notice that they limp when they walk. They do this kind of lurch. I encourage you to find some videos and look at a Trendelenburg lurch and see what that exactly looks like. That means they have osteoarthritis in their hip. If we were to palpate it and move their joint at the same time, we are possibly going to hear and or feel crepitus. This is that grating bone on bone sound and feel, I should say. If we were to just observe the joint, we're going to see that it's going to be enlarged, it's going to be deformed and knobby. This is due to bone hypertrophy. The cartilage breaks down and the bone will now overgrow and distort itself. When we do a hand assessment, because this disease can be unilateral and it can be bilateral, it really just depends on the patient, but we may notice at the very distal interphalangeal joint that it's going to be enlarged. If this is the case, we call this Heberden's nodes or Heberden's nodules. And this is the distal joint. If we see that the knuckle that you would knock with or box with, if that is enlarged, we call that Bouchard's node. Bouchard's node. This is the proximal interphalangeal joint. Do note that OA is not a symmetrical disease, as I mentioned, but these nodes can occur bilaterally. If somebody has, if you can see in the lower right picture there, inflammation, which can occur from secondary synovitis, this indicates advanced disease. We're going to see joint effusion, and it's going to be warm, it's going to be red, and very painful to touch and palpate. So I don't know if you can see that picture of the knee to the right there. This indicates advanced disease and secondary synovitis. Oftentimes what we will need to do is aspirate the fluid from that area, and that will actually help alleviate some of the excessive fluid on there, the joint effusion, and we can send it off for testing. If a patient does happen to have their cervical or even their lumbar joints affected, we will now see possible compression or the results of compression on nerve roots. And if this is the case, they're going to have nerve pain when they move their head or their hips in certain position. They're going to have stiffness and complain of muscle spasms. In most individuals with osteoarthritis, we are not going to have any changes noted in their lab work. However, if they happen to have a flare-up in one joint and have the result be synovitis inflammation of the synovium, we are going to see two inflammatory markers rise. The first one is called the erythrocyte sedimentation rate, also known as the SED rate, or we just say ESR. The ESR is actually going to rise naturally with age, infection, and other inflammatory disorders. It is often useful though, because if a person, we've ruled out that they don't have, say, inflammatory bowel disease or they don't have lupus, it's very useful in trying to figure out if somebody has secondary synovitis. We usually like to correlate our diagnostic findings with our physical findings to reach a conclusion of why it's elevated. The other inflammatory marker we are going to test for in this patient is called the C-reactive protein. This test is also sort of vague, but it is useful in monitoring people with chronic inflammatory conditions. It helps us detect flare-ups, and it's used to determine if treatment is affected. We will use it for our patient with osteoarthritis if they are having an episode of synovitis, and we use CRP for things such as inflammatory bowel disease, other forms of arthritis, and other autoimmune conditions such as lupus. Do note that neither of those two tests are specific enough to diagnose, but they do serve as a general marker for infection and/or inflammation. This just lets us know if other testing and treatment is necessary or if we're doing good. And the trend is going down. All right, on the right here, you can expect your patient with OA to have some kind of radiography done. The most common one is going to be an X-ray. This is where we're going to see some structural changes, maybe to the joint. There's going to be decreased joint space as well as bone spurs. We do also run tests such as MRI and CT, and this is going to detect any soft tissue injury that may be occurring. In this patient here, we actually have some very bony vertebrae that are actually starting to impinge on the spinal cord. That can be painful. When it comes to what medications are going to be given to a patient with OA, I want you to think Tylenol. Tylenol is actually the drug of choice for a patient who has osteoarthritis. Do know that we must limit how much Tylenol they get in a 24-hour period. It's important to know that they should stay below 3,000 milligrams in a 24-hour period. Encourage your patient to make sure they read the drug labels of any preparation of medication that they take over the counter, because it may not just be Mucinex Complete that they are getting. It could have additional Tylenol in there. When somebody is on Tylenol for like a regularly scheduled medication, do make sure to check their liver function periodically. We want to make sure that it is good and working well, and we are not giving the patient a medication that their liver is having a hard time processing. So, drug of choice, Tylenol. If the patient is having inadequate relief from their pain, then we proceed forward to administering NSAIDs, or non-steroidal anti-inflammatory drugs. What's important to know about these drugs is that we must monitor a patient's kidney function periodically, particularly the BUN and creatinine. We want it nice and below the 0.2 and 0.1 if possible. Looking at another lab we need to test, it's going to be their CBC. This medication can cause some GI bleeding, and if we're constantly monitoring their CBC every 6 months or so, then we'll be able to catch if there is a leak, so to say. We want to educate the patient that NSAIDs are nephrotoxic and should be taken as prescribed. And I will say that this is important to note because patients often have the idea if one is good, two is better. Teach the client to report evidence of black tarry stools, indigestion, and shortness of breath. The shortness of breath will usually also accommodate some edema and low urine output. This is a really bad finding and indicates that our kidneys are not producing urine and filtering like they should be. They need attention. We're going to instruct the client about the use of these medications prior to activity and taking them around the clock as needed. There is a topical NSAID that a patient can take. It is called Voltaren cream. Do make sure prior to applying this cream that the skin is intact, and we're going to apply it directly to the joint. And it does a pretty good job to controlling their pain. Some other medications that you may have ordered for your patient are lidoderm patches. You can take 3 of them and apply them to one particular joint area for about a 12-hour period, and then they need to come off to decrease the tolerance of the tolerance to the medication within those patches. You want the patches to work, so 12 on and 12 off. Make sure that the skin is intact prior to applying that and there's no open wounds. I sort of already mentioned the Voltaren cream. That is very useful, but let's add one more thing to the Voltaren cream. It does contain salicylate acid, or ASA, so do make sure to assess for aspirin allergies prior to applying the patch. Nope, this is a patch. Before to applying the cream. There's a cross sensitivity, I have so heard. Another good option for a topical cream is capsaicin. This is actually kind of neat. It's made from the alkaloid from a hot pepper, and it's to prevent the transmission of pain sensations. That's how it blocks it from the peripheral neurotransmitters. So fancy. But what do nurses need to know? We need to tell our patient to apply it with gloves and then immediately remove those gloves to prevent transmitting it to their eyes or another part of the body where it is not desired. So it will give the burning heat effect when applied, and that can relieve pain. Some other complementary alternative medicine methods are using glucosamine and chondroitin. Do make sure when somebody mentions glucosamine that they don't have a history of hypertension or diabetes. And I have heard that with chondroitin that we don't want concurrent use of NSAIDs, heparin, or warfarin because it has an additive effect to the blood thinners. Some other methods to relieve pain are injections of steroids. This is useful in the short term, but they don't like to use this long term. They may do this for a couple years before they need to replace the joint. One reason being is that the injections of steroids can actually degrade the bone even worse in there. One easy way to help your patient is to make sure they balance rest with activity. Good body mechanics is also very important if they have hip problems, back problems, or even neck problems. Put your computer at the proper eye level. Make sure you have a ergonomic keyboard. Any kind of body mechanic thing to encourage better alignment should be done. Encourage the use of splinting for joint protection. Here I have a picture of a wrist that is splinted. Let's see, for thermal applications, we're going to make sure that we encourage our patient to use heat to alleviate pain and then to use ice for acute inflammation flare-ups. They say cold therapy is not as effective as heat therapy. Do be sure to encourage the use of assistive devices to promote the safety and independence of your patient. Some examples include an elevated toilet seat, a shower bench, a long-handled reacher, and a shoehorn. Encourage your patient to schedule their high-energy activities, as you probably guessed, in the morning when they are well rested. Meal planning is important for balanced nutrition, but do know our goal is just to maintain an ideal body weight. They say that there is not one food that exists that can either cause or cure arthritis. No correlations there. The big idea is making sure the weight is ideal and a person has a well-balanced diet. Do consult a dietitian to provide meal planning for a balanced nutrition. We have a lovely list of do's and don'ts in your book, so please make sure to visit that chart and you'll see neat little things that you can do to help a patient with OA, such as, did you know how to open a doorknob if you have OA? Yep, you have to turn a round doorknob counterclockwise. That helps in alleviating some of the pain and rotating it the other way. As we conclude this lesson, I'm going to talk about the interdisciplinary teams that are going to be involved in our patient's care. The first one is going to be the physical therapist. Their services include muscle strengthening exercises, application of heat. They can teach a patient how to use diathermy, which is treatment with electrical currents. They can also do ultrasonography, which is treatment with sound waves. And the last but not least is stretching exercises. You can also consult an occupational therapist. They are extremely helpful in helping a patient figure out how to accomplish their ADLs. Do know that your patient is probably going to end up with some kind of assistive device. If it's in a hip, then expect a cane or even a walker. So my question to you is, what side does the cane go on? It's going to be the good side, the unaffected side. In fact, when it comes to walking with a cane, be sure to remember your alphabet, because I do feel like the sequence of the alphabet can help you in what goes first. We're going to remember the B, the C, and a G. That means the bad leg with the cane, and then comes the good leg. So bad leg with a cane, and then comes the good leg. One more time. Bad leg, and then the cane, and then comes the good leg. So just remember your order of your ABCs. Looks like we are done unpacking osteoarthritis. I hope you enjoyed this lesson and learned a little something new.